Okay, what is remote monitoring? You guys all know this, right? It's a little device that's on your arm. We talked about this on the weekly check-in today. People can put it other places. It's just not been studied by the FDA for the Libre on other places, but that doesn't mean patients don't use them. But I guess we're supposed to teach the back of the arm. So we're going to kind of just go over the highlights. This is like an info dump for those of you that haven't done RPM. And I think Whitney will attest to the fact that it's one thing to listen to this, and then it's another thing to actually start doing it at the clinic and looking at the documents and what pieces fit where. And that's where Hugh is such an amazing resource. He's like the high priest of, I guess we would be high priestesses and he would be the high priest of RPM. So he's a great resource and really generous with his time. So to reach out to him as well. But this is just we're just kind of go through these things. And once again, as I suggested, printing the documents off. And then Deb and Whitney, I guess if you have, and Tammy too, some comments along the way, because you guys do have some experience with the RPM, and Laura, you have a boatload of experience with CGM of all kinds.
But not with RPM.
Yeah. But this is like the big overview of the whole process. Mika put together this Visio diagram, and this is in one of your job aids. But if you ever get confused at who's doing what, you have access to these slides to look at, just to kind of look at the big overview, billing and such. So identifying patients who are eligible for remote monitoring CGM. We're focusing on patients with type 2 diabetes, maybe on insulin, maybe not. Could be people that are needing to have their medications advanced and are resistant to it. And this is a way that the providers, obviously can share with the patient what's going on with their glucose management. But it is not just people on insulin. It can be, as Hugh calls them, the worried well. I think he's had several patients that get a diagnosis of type 2 diabetes, their A1C 7.1, and they're really interested in a lot of help and what's going on, and then within a month or two are coming off of it. But so who's excluded? If a patient is receiving care from an endocrinologist, they would not be a part of RPM. Pediatric patients, gestational diabetes, and Dr. Wong, who kind of oversees and manages his program, says type 1 diabetes. We have had some patients that are managed in primary care. They don't want to go to the Diabetes Care Institute. Lori, we've met patients like that through the years. They want to be managed by their primary care provider. So if you do get a referral for a patient with type 1 and you talk to the patient and they just want to see their PCP, they could certainly be part of this program. So Tammy was saying, consider patients who are already enrolled in care management, maybe struggling with care. As we'll see here, your panel navigators might, in the process of having their panel management meetings, especially in patients that have care gaps, elevated A1Cs over 9, they might be somebody that the panel navigator might recommend during that panel management meeting. In terms of payer information, and I think most of all of you know this, but just commercial insurance, like you can have a heartbeat and pre-diabetes and you can have coverage for Libre. For RPM though, you need to have a diagnosis of diabetes to be enrolled, not pre-diabetes. Medicare, as we all know, you have to be on 3 or more doses of insulin per day. They say doses now because people do use inhaled insulin. Not very many of our patients in primary care or on an insulin pump, they no longer require BG test results to get CGM anymore from Medicare patients. Somewhere in the note, when the provider is seeing the patient and making the referral, somewhere in the note when that patient is seen, the provider needs to put a little note in there like they feel that they would benefit from CGM in the chart note. Because as we know, patients with Medicare have to have a DME, a durable medical equipment, filled out. And so the last couple of chart notes usually have to be sent with the completed DME application. So somewhere in that chart note, there needs to be some indication that this would be a benefit to the patient. How you can get around that is if you're looking at the referral for CGM and you're assisting with a DME at your clinic, you can put an addendum on the chart. Send it to the patient. The provider can just addend his most recent chart note. Medicaid's much more difficult. I think all of us know that as well. Not only do they have to be on 3 or more doses of insulin a day, but there has to be some statement in the chart that they are checking their blood glucose 4 or more times per day. They should have a note in there that there would be a therapeutic benefit. Okay. People can do this with self-pay too. You might have a patient who has, they are Medicare or Medicaid and they want to be part of this. They're newly diagnosed and they want to do it for a few months. So the physician can send a prescription for Libre 2 sensors and a reader if the patient's not using the app to their local pharmacy. The patient has 2 options. The patient can call customer service and request a discount voucher or coupon code number. They can also check online. There's things online. Or the other option is they can ask the patient to run the prescription that's been sent over to the big box pharmacy and run it through GoodRx. And that tends to be pretty inexpensive, typically $35 per sensor and maybe 60 or 70 bucks for the reader. Okay. Any questions about, everybody knew about self-pay, right? Okay. In terms of when a provider is in a visit with a patient, because the providers at the Shoreline Clinic and the Northgate Clinic, a lot of them sat through the introductory session that Crystal Wong, the head of this RPM program, gave a few weeks ago. And what she shared with them that providers can identify a patient in the context of the visit of a patient that would be a good fit. Then the provider needs to consent the patient. They have a smart phrase that they use. It's kind of like BHIP. They have to consent patients for BHIP. And this is the same thing for RPM. It has to be interactive though. So they can do it via an in-person visit, telemedicine visit, or a phone call. They can't do it during an interactive MyChart encounter. So, okay. The provider places a referral. They go to Meds and Orders and they look for remote monitoring. They drop the referral. And these referrals land in the care management nurse's work queue. So that's where you'll find them. Lori, that's where I found one the other day. Matt Jaffe referred a patient that didn't qualify. And then he prescribed Libre 14 days. So that's been the first patient, the one and only that's been referred so far. So anyways, in the clinics that don't have a nurse, because these are routed to the care management work queue, we have been encouraging the provider to CC both, the nurse or the dietitian, because sometimes you get you know, maybe you might not be looking in your care management work queue every single day or something. So, and especially the dietitians don't look in the care management nurse queue. So, okay. And then the physicians have an AVS that they can add that provides the patient in that context of that provider visit about kind of the nuts and bolts of the RPM program. As I mentioned before, the panel navigators might queue up an RPM referral for the physicians to sign. In the context of a nurse or a dietitian visit, you can also refer a patient to RPM as well. You are not allowed to consent the patient though. So if you do kind of penned a RPM referral to the physician to sign, you will have to follow up with the provider to maybe make a phone consult time to have them consent the patient. You know, this is something if you were explaining it to the patient, the RPM program, you would have to say, you know, you have to be consented. And do you guys know why they need to be consented? Because they're going to get a monthly charge. And especially in Medicare, there might be a copay.
Allison, how much is the charge?
I don't think for Medicare it's very much. It might be less than like $50 a month for RPM.
Mm-hmm.
What we have found though, and in some of the clinics like Woodinville and Ravenna, where there's been a few, if the patient is a commercial payer,
Mm-hmm.
has commercial insurance, they might have a high deductible or they might have a copay. So like Christina had, I think, 1 or 2 patients that, you know, had really high deductibles. They were younger patients and they decided to unenroll because, you know, they had a $5,000 deductible, you know, and so or maybe at the beginning of a year, a copay.
Mm-hmm.
Okay.
Thanks.
The other thing that Hugh has done, like if he's recommended or if he's seen, you know, if he gets a referral, he reaches out, he number one, see if they meet the criteria. He calls the patient, finds out if they're interested, you know, and if he sees that consent is not done and the patient is interested in signing up for RPM, what he will do is either before or after the device training appointment, when the patient comes in person to the clinic, he has that provider stop by either before or after or during the time that the patient's there to do the consent. Okay, any questions about consent? Okay. In terms of ordering the device, and I think I went through this a little bit, commercial insurance goes to a big box pharmacy. Medicare, it has to be a DME. There is a link here on this page, but there's also on the RPM website, which Mika will be sending you a summary of and a link to the RPM website either today or tomorrow or by the end of the week. And these DME forms are living there. What we find is they're not too difficult to fill out. Lori, you've probably done hundreds of them like me, working at the Diabetes Institute. You know, you need to, often you can fill it out for the patient. It just takes a minute. You print off some chart notes, you put it in their box, you sign it, and you fax it. One of the things that Linda and Christina and Hugh have found, who have the most experience with this, is it's good to make a copy and scan it. We did that at the Diabetes Institute with any paperwork we did, because then if it gets lost in the fax machine or whatever, you don't have to do it again. Or if they didn't get it on their end, you know, you can just print off that signed copy again. So I would really highly encourage you, if you do a DME, to make a copy of it and just upload it into the media tab. Medicaid, the prescription goes to the pharmacy. So this is something that the physicians have all been taught. They may not remember it, but this is where, you know, with the job aid that I sent today, I think Christina and Hugh and Linda will all say that their providers need some coaching in the beginning until they kind of figure out all these steps. But the Medicaid one goes to the big box pharmacy. And somebody needs to, either the patient or the care management nurse or the dietitian needs to ask the pharmacist to run it. And what will happen if they qualify, the pharmacist that you're talking to on the phone will say, oh, they need a PA, and that can be sent to the PA rack group at you, and that's in the, we don't have to do PAs anymore. You just have to get that fax form and send it on over to the PA group at UW Medicine. Okay. Any questions on that?
So just one thing. So this doesn't allow the doctor to do just the plain Libre, is that right? Or because we talked earlier today that they're running just the plain Libre. So under the CGM monitoring, are they only given one option at this point, the Libre 2?
So in this program, in the RPM, Becky, we are encouraging the provider to do Libre 2s. Yeah, because Libre 14 days are going out of, yeah, that came up on the call today, Tammy. I mean, maybe we can ask Epic to take the Libre 14 days off the list of things because they're phasing them out.
Yeah, because then what happens is the doctor goes ahead and orders just the plain Libre, it goes, if we don't get a copy of it or whatever, then the patient already has not the wrong device, but they don't have.
Well, the Libre 14 day will work, Becky, and if they've already picked them up at the pharmacy, I would go ahead and have them use however many. That's a great question, Becky. That's a really great question. I mean, I don't think they'll be able, well, if they don't open them, they might be able to return them, but it might be they just use the 14 day. And then when you start working with the patient, just pen to Libre 2 and have the physician sign that. So the next time they go get a refill, they'll get the Libre 2.
Can they use the same reader then?
Nope. It's a different reader.
So again, it's going to increase the cost for the patient for another reader, and
So I mean, and then with this RPM, Becky, sometimes it's easier to catch those things because you're going to get that RPM referral, right, in your care management work queue. So if you're looking at it, every day or so, you might be able to catch the patient before they go, reach out to them if you see that RPM referral in your care management work queue, right? And just say, Mr. Smith, don't get your prescription. I'm going to append a new one to your doctor. So what we're finding too is there might be patients that are already wearing Libres and the doctors encourage them to enroll in this. So they're already on CGM. So what you'd want to do is just, when they run out, just append a new prescription to the provider for Libre 2s. I think what we're finding with the RPM is like maybe 80% of the people, Becky, are using the app and not using the reader. So, I mean, Deb, what do you see in all the patients you're working with?
Oh, my patients are using the reader, but also
the reader.
No, I'm sorry, the app, but also I just misspoke. So they're using the app. Also, if they go from a 14 to a 2, they need the new app. It's a different app.
It's a different app.
Right.
Yep. And this is another thing this is one of the handouts that I sent to you. This is your workflow, the RDs and RNs workflow. And I think especially when you first get started, I remember seeing Christina or Linda, like on her filing cabinet by her desk, had this workflow when they first started doing the pilot, just because it helps remind you like the workflow. It's not the big giant one that I showed you on the first slide. So, and that's where, again, it's nice to have it in color. In terms of the first meeting that you have with the patient, they bring their sensors. They bring their smartphone or their reader. You know, you will have talked to them probably because you're scheduling their appointment. But at the first meeting, in order to bill for it, you have to do training on putting the sensor on. You know, if you want to talk to them about traveling or taking, you know, like subtle follow-up things, the device training is the one that is billed. So in your chart note for that intro visit, you really just need to be focusing on the device training. And then you're going to set up a follow-up plan with them. Most people, depending on the patient needs, have, you know, reach out via telemedicine or a phone follow-up within 1 or 2 weeks, you know, depending on the needs of the patient. There's a dot phrase, CGM RPM intake note that has, it's a really cool smart text note that kind of has everything in there that you need in order to do your charting. And I believe that the nurses are using clinical support as the encounter type, and I believe the dietitians, I don't know if we have clinical support. I think Christy's used the ones that she's done new. And this is just a picture of that intake note with all the little cool animations. And I have here on the top of the, if you want to practice, if you have an open patient encounter, you're going to see a list at the end of all these smart texts. I would encourage you, when you have an open patient encounter, to kind of play around with them and kind of look at them. You cannot get them to work in a telephone encounter. So if you try to use this, you know, this CGM RPM RN intake note in a telephone encounter, you're going to be really frustrated and it's not going to work. We had a ticket that we put in because Hugh and General Internal Medicine, when they rolled it out, nobody could find them in the telephone notes. And then we learned the hard way that they don't show up in a telephone note. So, but I really, and I think Whitney found this too, that it was really, like, we talked about these notes, but it was really helpful for her to actually pull them into a chart note and look and see what they look like. Just for you to know, when you're working with a patient and they're coming back for a follow-up visit, the whole RPM thing is pretty much so we help get the information to the provider to evaluate. At the Diabetes Institute, we had medical assistants that uploaded all this information, you know, for the provider for their visit. But this is a way in which, you know, a busy primary care provider can help a patient with diabetes looking at all this data. But the RPM does allow a nurse or a dietitian to be able to charge for their time. Because right now, when an MA uploads the data to the media tab, there's no, you know, there's no revenue generation. So the part of the RPM program, when you guys do your chart notes, you can count, if it takes 20 minutes of time, you can charge for that. And you send it over to the doctor. It's in the media tab. Well, you guys have a chart note that you fill out that you send over. You know, you do a patient outreach encounter, which I'll show you in just a minute. The provider looks at it. They can bill for interpretation. They send any comments back to you, and then the nurse or the dietitian can do a, you know, a follow-up with the patient. And if you do that twice in a month, you can bill 2 20-minute, it has to be at least 20 minutes that you spend with the patient. You can bill 2 20-minute encounters. So does that kind of make sense? So this whole RPM for CGM or for blood pressure, which is another remote monitoring program, just helps institutions and organizations kind of account for this previously lost time.
Allison, I have a question. So with item number 4, if the patient is unable to retrieve data at home, will need to return to clinic for assistance, but then they're not doing a remote patient monitoring.
Right.
So it's, how do you deal with that?
So, so some patients that use the app, right? You send them an invitation. That's part of your device training visit. You send them the invitation to your clinic. And you get the data. Part of the training too, the device training, is if you have, Becky, like if you have a patient that uses a reader, I think a lot of your patients down in KDM use readers. If you train them on how to upload their data with their reader, you'll reach out to them. Mr. Smith, you know, when we did your training, I told you I'd be calling you in a week. Here's our appointment. Can you upload your data to your LibreView account? You know, they have to accept your invitation, and then you pull the note. Hugh's the only one I think that's had, and maybe Hugh and Linda have had patients that can't figure out how to do technology at home. So they come into the clinic and they download it using the LibreView at the clinic. So it's not remote monitoring, but you can bill for it because you're retrieving the data, you're talking to the patient. Yep, Lori?
So related to that, if you don't have someone enrolled in this program, but you have a situation like what you just explained, where the patient does not know tech and brings the reader in every time I see them, can I bill for that part, the uploading?
Nope, not unless they've been consented and are part of remote monitoring.
Okay.
You could maybe do a 99211, right?
Yeah.
And the dietitians do that all the time. They bill it as diabetes education or MNT. I mean, because we see a ton of patients that aren't in RPM.
And then
you do that through telehealth?
What?
Can you bill through telehealth as well?
Well, so if you can reach out to the patient, Becky, through using RPM. I'll answer 2 questions. If you're doing remote monitoring, the patient's been consented, you're supposed to reach out to them via phone or telemedicine, because that's what makes it remote, right? They're not having to come into the clinic. If you have a patient that's not in RPM and you are working with them through care management, and Tammy might be able to answer these questions in terms of billing, you can use the medium of telemedicine to talk to the patient, right? And then bill 99211.
Yeah, that's what I thought. Okay.
But if you then pull that stuff, the AGP report into the note, and you have CC it to the doc, and the doc does something about it, then they can bill, right?
Absolutely. Right. Absolutely. So, absolutely. Like if the doctor can, you know, if the doctor calls the patient, you know, after you send them, Laura, you see that patient that's not part of RPM, they come in and see you, and you send your note to the doctor, and then they call the patient and make a medication adjustment. If they refer to your note, they can bill the 95251. That's what they used to do at the DI, right?
Can I also clarify, for the 20 minutes that we're billing for, that's 20 minutes of like interaction with the patient, right? That doesn't count like you uploading things to Epic and like retrieving the data or anything?
I believe that's correct. So you know, you've called the patient, Mr. Smith, you know, and then you retrieve the data and you're kind of looking at it, and you know, you might ask some clarifying questions like, I see that you're not scanning 3 times a day, you know, every 8 hours. And so you need to kind of keep track of your time. Once you get the information back from the provider, you know, you're sending the note, which I'll show you in just a minute, to the provider, and the provider is going to say, hey, Lisa, you know, follow up with Mrs. Smith. And so, you know, if you are gathering the data, touching base with Mrs. Smith, and then you call Mrs. Smith back with telling her to increase your insulin by 3 units, and it's 20 minutes, wink, wink, then you can drop that charge.
Gotcha.
Does that make sense?
Yeah, that does.
So if Mrs. Smith doesn't answer and you've already gotten the information, can you keep track of that time and as you keep calling, or do you have to actually only bill when you actually talk to the patient?
I'm going to jump ahead here. So this is the 95249. That's what you bill when you do the device training. And what we're finding, we ask billing and coding to run a report. This is actually getting paid pretty well by all payers. They're all paying for the device training. Now, once again, if a patient has a high copay, they might be, but Medicare and Medicaid are covering that. This is the 95251. That's the one that the doctor uses. So Becky, this says billed for the first 20 minutes of an interactive patient phone call or telemedicine visit or e-care messaging. So you guys, because it's remote monitoring, the physician cannot consent the patient via e-care messaging. But if you're taking 20 minutes to get, you've sent the info, you've called the patient, they've uploaded, you've never talked to them, you're retrieving the report, you send it to Dr. Smith, and then you take 20 minutes to chart a note from Dr. Smith about Mrs. Jones. It says here, e-care messaging or face-to-face. You can bill that. Does that make sense?
Hey, Allison, I'm not sure. Two things.
What?
Two things. Can you hear me? Two things I wanted to say. One has to do with Becky's question, because the way I heard Becky's question, I might have heard it differently than you, or so I think Becky was asking that question about, it's also one of those, it's a little bit similar to what Lisa said, but Becky's asking, or Becky, can you restate your question? It sounded like you were asking if you're doing all this stuff for the patient and you can't get the patient, can you keep track of that time when you finally do get to the patient? And can you track, Becky's asking, can you track time if you never talk to the patient?
Yeah, that's kind of, yeah. So let's
Well, it
say,
says e-care messaging. So,
but not by phone. So you have to do e-care.
It says phone calls, telemedicine, e-care messaging, face-to-face visits, interactive.
Okay.
So if
Becky,
you're leaving voice messages, that's not interactive. But if the patient calls you back and leaves you a message, that's interactive, right, Becky?
Okay.
If you e-care message a patient and say, please adjust your insulin 2 units, let me know, and they send you a message back, that's interactive, right? So
Okay.
Tammy, I don't know. No one's ever asked that question before. I don't think if you never
the way I
have
heard
a back
Becky
and
say
forth.
Yeah, that I was just asking because of what Becky said. Also with Lisa's question, I think there's a little bit, I think we're still waiting for a response from Clarissa. Remember? So it's the way you answered her, and you answered her correctly, but I think there's some noise. We're still waiting for some answers from compliance, I think. Aren't we, Allison?
Yeah.
Yeah. So there's some
because the
follow-up.
physician getting backed, it's kind of like we're billing this incident too. So what we've been kind of told by compliance, we kind of have to hear back from the provider. Isn't that right? Before we can really drop the charge, right?
Yeah, right. Because what we are really billing for is what we think we're really billing for is we did all this work, but we have to send that information to the provider and we have to get a decision back from the provider to do something or not to do something, what to communicate to the patient. So what we're really, when we're calling that patient back to say, this is what the provider has interpreted and what the provider wants to do, that's really what we're billing for. And all that prep work to get all the information together is what we're trying to find out. Is there any space to bill for the prep work when you send the stuff to the provider?
Exactly. Or even before you get a hold of the patient, you've gathered all, downloaded their information, and then you try to call them and you can't reach them, and, oh, but maybe
Yeah.
by the fourth phone call,
But-
then you spent 20
But,
minutes.
but
just on that.
Becky, so I do agree with Allison. Once you kind of call the patient, that's a different story. But we're just saying is what we're trying to be clear about. If you're just pulling all that time you spend pulling the information together to send it to the provider, people were asking, I mean, some of that might be calling the patient, asking the patient questions, but we're trying to find out before you send it to the provider and you get clarification on what the provider wants you to do, can you bill for any of that time? We're not quite 100% sure on that. We need an answer from compliance, okay? I think what Allison is directing is once you have heard back from the provider and you're trying to get the patient, you know, it's interactive because you're communicating to the patient. Am I saying that correctly, Allison?
Yeah, because we're not billing this under our name. We're billing this under the physician name. So we're taking our direction from the physician. So that's where, you know, it's been, you know, because I mean, Tammy and I originally thought all the time we spent pulling and retrieving that would count, but it sounds like build one time, you know, build for first of an interactive patient care. So that's language that comes right from CMS, interactive patient care. It doesn't say the amount of time the nurse or the dietitian spent retrieving data the first time she tried to do it and it was an hour. Or Deb, did it take us 45 minutes? So
At least 45 minutes the first time.
two of us
It was fancy.
trying to screw in a light bulb at
Yeah.
Factoria. Yeah. So, yeah.
Sorry, I have one more question.
Oh, no, these are great. These are great.
So say like a patient is very interested in the Freestyle Libre and they're not on insulin, but they are like a type 2 diabetic, so they qualify, and they're mostly in it to do like the diet lifestyle education portion. Would that qualify for
Absolutely.
RPM?
Absolutely.
I guess what is confusing is the if I were to I can do the education piece of it, but I'm confused what the provider would really what I guess their decision would be regarding if I send it to the provider, am I supposed to expect something back from them or just like a okay, keep going kind of
That's
deal?
exactly what you would do.
Okay.
So see, it says, you know, identifying patients and or difficulty with glucose management, hypo or hypoglycemia, unwilling to use a meter, those interested in tailing lifestyle fluctuations to glucose.
Okay.
I mean, you know, for us, this is kind of our bread and butter here.
Mhm.
So we send it up to the provider looks at it and says, looks great, keep doing it.
Okay.
So then you
So-
call the patient back
yeah.
and say, I talked to him and looks great. Then you can bill your 20 minutes and, you know, you haven't done any med adjustment at all. You've been coaching them on healthy eating or look what happens on the days you exercise, you know.
Gotcha. Okay, so it's really just provider oversight, not necessarily making any med changes or any other.
It could be med changes,
Okay, but it doesn't have to be.
it absolutely doesn't
Gotcha.
have to be.
Okay, cool.
And let's not forget the physicians for the patients on insulin who also say it looks fine.
Deb, so you need to elaborate on that.
Well, sometimes it's could be altered and it isn't, like more or less basal insulin or things like that. And I don't want to get in trouble, although I probably already am.
No, but I mean, you guys are now all have diabetes competency,
Mhm.
right? Deb and I have done a few patients together with this Libre Pro with a group of doctors that have not really used CGM before. And we send them up the reports. Their, you know, their AGP shows that their A1C is 10 and their blood sugars are on average 300 and they don't want to make any medication adjustments. And that's where I think hopefully we all have the, you know, the confidence and the skill in our knowledge to say, gee, doctors,
This
You know what I
patient
mean?
would be great for a GLP-1
Or,
basal
yeah.
insulin
Or they've done every diet thing and they're exercising and their blood
Mhm.
sugars are still 200. You know, I
Right.
mean, we're advocating for the patient, and this CGM is hopefully supporting that visually for them. So anyways, and this is the time consuming part, and this is where your guys' heads are going to explode, and I apologize for that up front, and where Whitney found out, but you just have to do it a few times and it'll go a little bit quicker. There is a job aid. I attached it to the information I sent you. It's also, if you lose it, it's part of the remote monitoring materials. But there is a job aid that shows you how to retrieve the LibreView report from AGP. Laura, you do this in your sleep, so you don't have to worry about it. But Lisa, you might really want to, you know, pull this off and have it sitting in a folder right by your desk. You know, the first, and Deb's nodding her head too. She can do it in her sleep now too, but it just kind of walks you through on how to create that AGP report. And thanks to Hugh and Christy for putting these together, because the first pilot clinics didn't have these. And Hugh and Christy both kind of said, wow, we need something like this for everybody. The other thing that Dr. Wong wants us to do is go to the flow sheet section of Epic. You can see the little tabs across the top of the chart note. And you want to type in a diabetes MA note. And what they would like us to do is to put in the GMI from the AGP report, the time in range and time below range. And what you can do when you put it in a flow sheet, if the physician or you yourself is working with a patient, just like weight or blood pressure, you can put it into a graph for the patient. So, and this is something that is, if you put it into a flow sheet, can be extracted for looking at how our patients are doing, you know, on, so that's one of the things. Once you get your AGP, when you're in the patient chart, you're going to pull up this flow sheet and you're going to put in that data. This is, so you had a CGM, RPM, RN intake note. And this is the CGM, RPM, RN follow-up vote. And this is going to be on a list of, which is one of the handouts that I told you. These are the smart phrases that you will be using. And once again, you're just going to F2, CGM, date range, GMI, percent Goldage range, high glucose. You know, when you talk to that patient on the phone, here's the section to your point, Lisa. Like you might say, you know, this is a patient that's on metformin, they're tolerating it fine, and you're working with them on lifestyle behaviors. You might put that little narrative section in there, send that up to the patient. That goes to the patient, to the provider. It's routed, and you're going to say that, you know, please look in the media tab, and you're going to put how much time, you know, you talk to the patient in that. Once again, when we get to 20 minutes, we can bill for it. Let's see here. The provider will review the note. The provider might follow up with the patient themselves, but I'd say most of the time it's the nurse or the dietitian that's following up with the patient. They have a CGM RPM interpretation note that the doctors or the PA or the APP uses. And then the RN, the RD, you know, if you're the person calling the patient, you'll be, you know, reaching out to the patient. Okay. This is just the AGP report. I think all of you guys have seen this. Why I kind of just bring it up is the patient has to have 72 hours of data. So if you look the glucose pattern summary, August 1st, 2018, it says 28 days. If you see less than 72 hours, you can't bill for it, anything. The patient has to be wearing it for at least 3 days to do the interpretation by the physician for you to bill your codes. Okay. So it might be that the patient just has to do it for another week and you have another follow-up appointment in a week. I think you guys know how to see all these. Our goal is 70% time in range or above, but it might be your patient is 32% time in range, right? Let's celebrate that. And if you follow up with them in a week and it's 38, woohoo! I mean, it's not bad if our goal is to get to 70, but we want to, some of our patients are going to make small progress. The main thing though is if you have a patient that's having a lot of hypoglycemia, there's like 3 pages to these AGP reports, and we really want to make sure that if your patient is having significant hypoglycemia, if you have a patient that's under goal, 10, 11, 12% of the time, that's an immediate, like, go find the doctor and get something changed, and that'll be on your AGP report too. This is something that's really helpful, Lori and Deb. I know you've seen these, but if you're getting breaks in data, Lisa, it might be because your patient's not scanning enough. So this is a monthly report that shows the patient only scanned twice on the 5th, and they scanned 8 times on the 8th, 12 times on the 7th. So if a patient's scanning less than 3 times a day, they're going to have breaks in their data. So this is a way for you to see if the patient's really maximizing their use of their CGM. And just to show you, like Lisa, on August 10th, if you look at this report, there's this huge gap, and that patient just didn't scan for 8 hours. So this is the coding and billing chart. Once again, this is one of the ones that I really highly recommend that you Scotch tape to your filing cabinet, in terms of, it's a really useful thing in terms of helping you or your providers know what to bill when. This is the job aid. It's like 8 pages long. It's also attached to your email that I sent. I would definitely print this off, staple it, do it in color, put it in your folder, because you are going to refer to it a ton. And these are just some screenshots of you. If you're the nurse and you're billing, you go to charge capture or Deb, you drop in 95249. That is the device training one. And once again, that one always has to be in person. You cannot do the device training via telemedicine and charge for it. You can do it via telemedicine, but you can't charge for it. If your patient already got their CGM and they put it on, you can start working with them with the follow-up visits, these charges 99457 and then 99458, 20 minutes for the first one, 20 minutes for if you work with them twice in a month. But Stephanie Dolan at the Ballard Clinic had all these eager beavers when they first rolled out the RPM at the Ballard Clinic, and I think her first 3 out of 5 patients were already wearing it. So she couldn't bill the device training. She just had to start with follow-up visits. So, okay. And I think this is one, there's a picture of this in the job aid, but these are all the smart texts that have been developed by the Epic team for the different types of notes. They're Mika,
Yes.
I think we need to update this, and there's one that's missing if the patient wants to unenroll.
Oh, yeah, you are.
So we need to get
right.
that one on here.
Yep, we do, and we will.
Yeah, so there is a note. It is in your job aid, but it's not on this slide here. So, because you might have a patient that after 3 months, they don't want to be part of it anymore. You know, they can keep using their CGM. The doctor can look at the data in the LibreView account, but they just don't want to have the monthly charge anymore. Dr. Subrabadian did a 60-minute presentation about remote monitoring. There's a link here. There's an excellent YouTube video. Lisa, you might want to watch this one. It's done by a physician assistant that is a clinical specialist that works for Libre. And it's 15 minutes on how to read an AGP report. Just takes you through each section. It's just, in 15 minutes, you're going to get everything you need to know. It's just a really great, super useful 15-minute video. And then there's the link to all the job aids. But once again, I would save the email that Mika's going to send you in a day or two, because he'll have a link in there. And I don't know how many times I've gone to one of my emails, because everything that you're going to need is on that link. And then what a lot of the nurses, and Christy comes to some of them. I don't know if Deb has and Whitney, but I would highly encourage you. They're at 11:30 on Tuesdays once a week, just a half an hour check-in where everybody has cases they're reviewing, best practices, questions. So it's a really great, wonderful check-in.
Yeah, for the RNs, actually in the beginning, you're going to be required to come, because the RDs, you know, even though this was rolled out new to them, they have been doing this for a while. But for the nurses, Lori, you might be an exception if you couldn't come. But for everyone else, you haven't done this before, we need you to come to the huddle, 30-minute huddle. It's going to be invaluable for you.
And I think Lori should too, because she hasn't had to navigate all this crazy paperwork, Tammy.
Yeah,
And
she
Deb,
should. But
I
I'm
would move-
saying,
yeah.
if I was going to give somebody it would be Lori. But I definitely, the people who have not been coming, who have not done this, you need to come to that meeting. Lori, I agree with Allison, because recommended you come. But if you couldn't because of something else, I mean, you have experience. But one other thing I wanted to ask you, Allison, and this is a clarification, Allison. So like the question that was asked about people who are already on the device. So like what, an example you were using was Stephanie. One of the issues that Stephanie had was the people who were on the device, at least a couple of patients, they didn't want to come in.
They refused.
They refused to come in. So that refusal meant that we could not go back over to make sure that they were using it correctly. So my question, Allison, is if they already have it set up, if they already have it on, but they do want to be enrolled and they do want to come in, and we go over the device, because the billing for that first code, 449, I think it is, that's device setup and education. So if they already have it, but then we go over it just to make sure they have it set up correctly, and that, you know, we offer the education in that scenario, could we bill?
You could do a 99211, or the
But not-
dietitians could do a DSME, or they have, I mean, we ran that one by compliance. They have to be in person.
No, okay, that's what I'm asking. If they already had the device put on, because some people are tech savvy and they put it on, but they're willing to come in to just go over with the nurse.
Oh yeah, I think you could bill.
Yeah, that's what I wanted to be clear about.
Oh, I don't know. Let's look at the slide.
Yeah, but if they refuse to come in, then you cannot bill.
Did you guys see my screen, or did I take it off?
You took it off.
Okay, so let me.
So Tammy, if they refuse to come in, but they're willing to do a telemed So that's where, Allison, isn't that where
No,
you're
no, no,
saying we
no.
could bill at 99211?
So for device setup, the initial device setup and education, it has to be face to face. It cannot be telemedicine.
Right, right. So you
Okay.
wouldn't bill that. I mean, so I'm just, you had mentioned, you know, if they didn't want to come in like Stephanie's patients, but they wanted to be part of the program. So if you did a telemedicine to review, like Tammy, you had mentioned, to go over like some do's and don'ts and things that they may not know about.
Oh, okay, okay.
And we could do the the telemed code.
Yeah.
Yeah, you're right. The
Or
99211 is
if you
telemed.
happen to be on the phone with them, you're pulling the data and you're looking at it. To Lisa's question, she's doing lifestyle intervention and, you know, maybe they don't need them. You know, it seems to me, wink, wink, part of your 20 minutes, you know, if you're spending time on the phone, you know, you've retrieved the data, you're looking at it with the patient and they have some questions. It seems like you could go over some stuff then for sure. Don't you think, Deb and Tammy? Like
But can
living
you
with it?
but in that scenario, I don't know that you can use the 5.7 and the 5.8. Is that the code you're talking
It
about?
says interactive patient care. That's right from CMS.
Okay,
So
so
that seems pretty loose to me.
yeah, that's why we need that clarification question, because
Yeah.
technically those codes are supposed to be used after the provider has given some directive on what the patient should do, right?
Yeah,
Or
but
that's what we're trying to clarify.
yeah.
I think I think that so we just want to make sure that everybody's clear.
Yeah.
So if that patient has already put that device on, and let's say that it's the start of remote patient monitoring, and they don't want to come in, as Allison said, if they don't want to come in, we can't bill for that first code.
Right.
If they don't come in, because that first code is they have to be face to face, no telemedicine, face to face. But what we do want you to do, we do still want you to make sure they're set up correctly. We still want you to make sure that they have the teaching and the education piece, because that's the piece they're really missing out on. Then that's when she's saying you can do 99211, you can do it telemedicine, right, Allison?
Or the dietitians could do DSME or an
Yeah,
MNT,
yeah.
you know, in the context
Okay.
of that kind of an appointment.
Right.
And yeah, see, and this is where, like, this is the note that was designed for us.
Hey, Allison, we can't see your
Oh,
phone.
shoot, sorry. So, Zoom. And this is, you know, this was a pilot. Tammy and I are trying to figure this out. You know, it's hard. But this is where Tammy and I got confused, just to be fair here. Let's see. Share screen.
And again,
So
sorry,
see that this is the dietitian and the nurse note, right? You put the date and range, the GMI, you're sending any information you got from the patient, and it says right here, I spent blank minutes. So it's kind of almost directing you. This is where I got confused, you guys, to be fair, you know, because it says here, I spent so many minutes with the patient's care, and that has to be at least 20, right? In order to bill for it. So that's where I thought, and I think Hugh has been too, and so has Christy. We've been billing it when we send this note over to the doctor.
Yeah.
What's the difference between the subsequent visit and the follow-up visit? Says this says 5.7 is billed for the first 20 minutes. I'm looking at this thing. Billed for the first 20 minutes of interactive patient care.
So then you send it to Dr. Chafee, and he says, have the patient increase 5 units. So you say, Mr. Jones, increase 5 units. Let's meet in 2 weeks over the phone. And so if you reach out to that patient in the same 30-day period, Deb, you can bill the next one.
Okay.
So if you only start your encounter at the beginning of the month, you know,
Right.
at the beginning of the month, you might have 2 opportunities, you
Sure.
know, 2 separate distinct opportunities. If you're seeing the patient on the 20th and because remember, you have to have 72 hours to bill for it. So, you know, at least a few days has to go by.
I wonder if this is an error then, because on this thingy, it's that I printed up now, they show 99457, they use the subsequent visit, and 99458, it also says subsequent visit.
Yeah, it's just
Oh.
basically saying Allison, I mean, not Allison, I'm saying Allison because that's what it says, Deb.
Yeah,
I believe what it's just saying is, within that time period, the first time you outreach the patient, once you reach 20 minutes, you bill 5.7. If you spend additional time in that time period with the person,
right.
then you use
Right.
the 5.8.
Right.
That's how
really
I read
what-
that too. Yeah, I see that.
Yeah.
Please note that all patients must be enrolled more than 16 days. Okay,
16 days.
that's what it says on this one, but it was revised 3/17/21, and I wonder if it's been revised again.
Well, that's the other thing. When the date got put on there, Mika, we put on 21 instead of 22.
Okay,
Yeah, I will correct that too.
But Deb,
yes, ma'am.
so I wonder if it's maybe, I don't know, oh my God.
I'll
So that's
look.
where,
I just happened to be actually reading it now. I
Yeah.
thought I understood it, and now I'm confused, so I'll
well,
keep
but I
looking.
mean, I think too, is it the physician maybe has to have 3 days to bill 95251, but does a dietitian and nurse have to have 16 days? I don't know. I'm not looking at that sheet.
It says enrolled, so that's like if they quit after 14 days. I don't know. Anyway, I'll figure it out.
Well, Deb, that's another one we need to send to, because this verbiage comes out of
Mhm.
compliance. Let's see.
Got it.
So where is it, Deb? Where's the
So
16-day
that's
thing?
this thingy, telehealth continuous glucose monitoring billing guide, this one that I
Mhm.
just printed up right now. It's horizontal. Let's see where that is in your emails.
Looks like it's on the top where it's really small.
It's
print,
very
please.
small.
Yeah,
Where's your email? Let's see. I don't know.
is it, please
The
note that
one
all patients
pager.
must be enrolled for greater than 16 days.
Did you find that?
Very top, just below UW Medicine continuous glucose monitoring.
I don't know which one it was.
So let me send, and it's the billing guide one, Deb.
It says billing
Yes.
guide, yeah.
In your slide deck, it's on page 28. I see what they're talking about. It says
Yeah,
must be enrolled for greater than 16 days.
So maybe they have to be enrolled for 16 days, but the provider, I think, can only bill if it's 70. Is
There
this
you
the
go.
one you guys are looking at?
Yeah.
Yeah, very
That
top.
actually makes sense that in order for the provider to make an interpretation, they need at least 72 hours of data. But from a billing standpoint, from an insurance standpoint, I think they would think if you're going to use this like you're in a program, you have to be in the program for a certain period of time before they will reimburse.
Because I know what most of the nurses and dietitians have done so far is they start the patient and then they follow up with them in 2 weeks.
Yeah,
So that would kind of check that box.
right. So provider
then-
interpretation is 72 hours to make a decision, but enrollment in the program to actually bill for anything, you
Is
got to be in it
16
for
days.
Yeah. Uh-huh.
So you just set the device up, the patient goes and lives with it for a while. So from the day that you do the device training, then that is the start. You guys are good because no one else has ever seen that, Deb, or asked that question. So
These kind of topics are literally what happens in the huddle. So,
Yeah.
yeah.
because what we found was that, I mean, Savitha and I, worked and, Lori's was at the DI. We kept thinking like, it'd be so great to do this in primary care. Mika, can you turn off the recording now?